Okay. Welcome to the American Academy of Family Physicians Procedural Skills Workshop on Joint Injection and Aspiration Skills. My name is Dr. Mark Mirabelli, and I'm an assistant professor at the University of Rochester School of Medicine in the Department of Orthopedics and Family Medicine. I work as a team physician at Rochester Institute of Technology, St. John Fisher College for the Rochester Nighthawks and Rattlers. I also work as a ringside physician for the New York State Athletic Commission. This package is part of an overall curriculum designed by the American Academy of Family Physicians on topics of interest to the family doctor. Like all AAFP CME, it is family physician produced and free from outside influence. Thank you for joining me. Let's get started.
That was excellent.
There you go. There you go. Okay. So now you rolling there? Yes, I am. Anytime.
After obtaining informed consent from the patient, normally I have an office assistant help me set up for my injections. Now, for the purpose of today's video, we will not be prepping before every injection, nor will we be using an ethyl chloride spray to help provide topical analgesia. For demonstration purposes, we'll do this once. I'm going to be using some medication. This is chlorhexidine, which is an antibacterial soap to clean your elbow prior to the injection. With chlorhexidine, you only really need to go on once and in concentric circles starting from the inside working out. Many people will choose to use betadine, which is an equally effective product. Either way, once the prep has dried, the injection can be performed. Normally, I would be doing the injection with my assistant helping me, spraying some topical ethyl chloride for about 3 seconds on the area of concern until it turns white, and then the area will be anesthetized enough to perform a comfortable injection. We're now going to discuss indications and techniques for injection of the shoulder. The first injection we're going to discuss is the injection of the subacromial space. Indications for injection in this space are subacromial bursitis and rotator cuff syndrome, also known as impingement syndrome. When we've been confident about our diagnosis, the injection technique that I usually like to take is a posterior approach. We identify the subacromial space by finding the spine of the scapula and going all the way out to the tip of the acromion. Just inferior to this is a soft dimple, and about 45 degrees towards midline on the opposite side, I can feel the coracoid process. Now, following a sterile prep and application of a topical analgesic spray, and using a 10 cc syringe with a 22 gauge 1 1/2 inch needle, and using 8 cc's of lidocaine, 1%, and 2 cc's of steroid, I would then insert the needle as far as it would go, 1 1/2 inches in, aiming towards the coracoid process about 45 degrees, and tipping the needle slightly to accommodate for the roof of the shoulder at approximately 30 degrees. I do not start injecting until the needle is all the way in, and I don't remove it until it's completed. As soon as I'm done injecting, the needle is rapidly withdrawn and some pressure is applied. The area is then cleaned and a bandage is applied. The subacromial space can also be injected using the same supplies from a lateral approach. Rather than the posterior approach, which may take a little bit further to get in, the lateral approach is much more shallow. You could still use a 22 gauge 1 1/2 inch needle, or if you wish, you may use a 1 inch needle. Finding the tip of the acromion, again following sterile preparation and application of an analgesic spray, we would inject directly in this area here. There are other indications for injection about the shoulder as well. Injection of the glenohumeral joint is commonly done from an anterior approach. It can be done posteriorly, but this is difficult and it's easier to do from an anterior approach. Indications for injection of the glenohumeral joint include glenohumeral osteoarthritis as well as a tear of the labrum. To identify the glenohumeral joint, we again find the clavicle and the acromion and the acromioclavicular joint. We can also find the coracoid process here below that. Using this, we can find an entranceway to the glenohumeral joint in the anterior shoulder, being careful to avoid the cephalic vein. To inject this joint, I again would use a 10 cc syringe with a 1 1/2 inch 22 gauge needle. I would use 8 cc's of anesthetic. Typically I use 1% lidocaine with 2 cc's of steroid. After sterile prep and application of topical analgesia, the needle will be introduced directly straight back into the glenohumeral joint. Minimal resistance should be met, and then the injection would be performed. Once the medication is injected, the needle is rapidly removed, the skin is cleaned, and the bandage is applied. Another injection that can be done about the shoulder is at the AC joint. The acromioclavicular joint at the top of the or roof of the shoulder is oftentimes affected by osteoarthritis and may also be injured with an acromioclavicular separation or sprain, which can result in long-term pain. This is a superficial joint and it's quite shallow, and therefore I use a smaller needle with less medication. I use a 3 cc syringe with a 5/8 inch 25 gauge needle. I use 2 cc's of anesthetic and 1 cc of steroid for this smaller joint. Again, after application of sterile preparation and topical analgesia, the joint is identified and the needle is directed down from superior to inferior fascian. The final injection about the shoulder is of the biceps tendon. The long head of the biceps tendon can be identified in the bicipital groove anteriorly in the shoulder, and again feels something like a lump of spaghetti. In people who have proximal biceps tendonitis, they will have pain in this area and pain with Speed's test. Once the diagnosis has been confirmed, treatment with a cortisone injection is oftentimes helpful in relieving symptoms. After sterile preparation and application of topical analgesia, I will use a 3 cc syringe with 2 cc's of anesthetic and 1 cc of steroid with a relatively shallow needle, perhaps a 25 gauge 5/8 inch needle or a 1 inch needle at most. And then the injection will be performed right next to the injection of the tendon site in such fashion here. Again, after the medication is instilled, the needle will be removed. The goal here is not to inject the tendon, but to inject the peritenon next to the tendon.